Hello Insta family, it's Dr. T here on Tuesday night. Yet another rapid fire Q&A. I've got to tell you, I am feeling just a little flat today, a little bit tired, but I'm here. So if you do have any questions, please don't hesitate to drop them in the chat. Just a couple of rules and regs around our Q&A rapid fire. Make sure that your questions are as generic as possible. Don't really want to answer someone's life story because whatever answers I give are going to be as generic as possible so that if there is someone else that has the same question, then they can benefit from the answer as well. But lovely to see a lot of people jumping on. Good to see you guys. Yeah, I don't know about you guys. I am finding this run down to Christmas absolute chaos. I find it's exactly the same every year, do you? I always find I get to sort of Halloween and then like the accelerator just goes and then all of a sudden it's Christmas and I'm like, where did that 8 weeks go? Crazy time. Hey, already got a question. Good work. Let's have a look. Where'd it go? Hello. Gemma Yapicha. HyCoSy shows a blockage. What options are next? Ooh. Well, I guess if it's a unit... Well, all right. First thing to understand with HyCoSy is you can get tubal spasming. So it might be a false positive test. If it's unilateral, less likely to be so. But if it's bilateral, then it is possible that it could be tubal spasm. So if there's obvious risk factors for tubal obstruction, endometriosis, PID, adhesions, then I guess you can look at IVF as an option. If the diagnosis is not certain, you can always progress to the gold standard, which is diagnostic laparoscopy and passage of dye through the tubes. And you look at it under direct vision and also look to see if there's any pathology that's potentially treatable. Very few people do canalization of tubes or salpingostomy anymore. The main reason is that tube is damaged, essentially, if it's truly blocked by adhesions, and no amount of surgery is actually going to necessarily improve your outcomes. Your tube is an organ in its own right. There's little ultrastructure, little cilia that push the eggs one way and sperm the other. And so by virtue of it being damaged, there'll be scar tissue, and that will affect its ability to function, even if it's open, even if it's not a hose pipe, put it this way. So, I mean, you've got a few options there. Certainly talk to whomever organised the HyCoSy for you about what your options are moving forward. Okay, good question. Kayla Jameson 1, history of endo, beginning to how long to wait until another surgery is needed? Is another surgery needed? Well, Kayla, it really depends on the severity of your disease, but I would say to anyone who has endometriosis and you know you've got endometriosis, then I would give yourself no more than 6 months of trying for spontaneous conception before you seek some assistance from a fertility specialist. And you're absolutely right, it may be that endometriosis is not necessarily best treated laparoscopically. It might need to be overcome by fertility treatment or even medical suppression of your endometriosis. But certainly go and have a chat with your fertility specialist after you've been trying for about 6 months. Of course, you need to take it into consideration and understand that women with endometriosis tend to do more poorly with fertility treatment. So you want to get stuck into it sooner rather than later. Hence why I say don't leave it for 12 months. Ali B, how do I extend my luteal phase, ovulate around day 25, period comes on day 30? Well, that sounds very not right, Ali B. So the first thing you need to do is go and get a proper cycle tracking with blood tests and ultrasounds, because it does not sound correct that you're ovulating on day 25 and then 5 days later having a period. So I think you need formal confirmation of that. And if that is truly so, then you have a luteal phase defect, and I suspect that you need to have that luteal phase supported with progesterone talk to your fertility specialist about it. Great question. Montana Arden. I am racing through these today. Hi, Dr. T. Hi, Montana. Have now had, I don't want your life story, Montana. Have now failed 2 rounds of IVF, 2 eggs both times, day 5s. Will go back to natural, but feel like I have no hope with such an incredibly low AMH1 ovary. You have to discuss this with your fertility specialist, Montana. There are a lot of things at play there. Certainly, yeah, it is a bit of a struggle, but I guess it depends on how far you're willing to go and what you're prepared to do. I would definitely go back and have a chat about what your options are with your fertility specialist. I don't think there's no hope, my friend. I don't think there's no hope. It's just how long are you willing to continue on with treatment. So keep going, Montana. Keep going. There is always hope and there is always opportunity. And sometimes you just have to think outside the box of how it is that you're going to achieve a family. So best of luck. Sorry, don't apologize. Don't apologize. I just started reading them and going, yeah, this is really specific, but hopefully somebody else has a similar situation to you and they will benefit from that. But seriously, have an open and honest discussion with your fertility doctor. This whole journey is various shades of grey, right? And it's a shared decision making that you make with your fertility specialist. Yes, there will be times when we say to our patients, look, I think moving forward is futile. Definitely. Have I had that conversation? For sure. Do I have it every week? No way. Like once in a blue moon. But I still also believe that you need to turn 60, you and your partner, and you need to be able to look back over your life and know that you did everything in your power that you could. And you want to know that you left no stone unturned. So I do think that it's a shared decision-making process that you make with your fertility specialist. Your fertility specialist's job is to, I guess, offer you the pros and cons, talk about the statistics and chances of success, and then that's up to you to make up your mind whether you continue on with treatment or not. Mum in the making. Hello. Good to see you again. Anything outside the box to ask for last embryo, FET, multiple miscarriages, implantation rates, and early loss? Oh, I'm so sorry. That sounds like a really challenging journey. Anything outside the box to ask for? Yeah. So I met with a couple today. And we were talking about recurrent implantation failure. And look, every story is slightly different, right? But I think what is really important is to go back to the basics, go right back to the very beginning and start the history taking process, do the examinations and investigations again. And I think it's really imperative that every now and again, your fertility specialist just takes stock of, is there anything that I have missed? Is there anything that I could have investigated, should have investigated? So for me to sort of say anything outside the box, I guess it depends on what in the box you've already tried. So I do think it's imperative that you and your partner are fully investigated. All the possible impact factors are looked at. Is it an embryo issue? Is it an endometrial receptivity issue? And then, categorically go through things. So is it chromosomal abnormalities? Is it endocrine issues? Is it anatomical polyps, fibroids, shape of the uterus? Is it a luteal phase defect? Is it something to do with clotting system? Is it to do with the immune system? How are you as the temple? How's your partner as the temple and, the place where sperm are made? So I think it's really, really important that you take stock and go back to the beginning and start again. I don't know your history around your endometriosis. Have that chat with your specialist. Maybe it's not necessarily about surgery. Maybe it's about medical suppression, but definitely go and have a chat. And as I have said time and time again, women who have endometriosis will do more poorly with fertility treatment. So you got a woman with blocked tubes, let's say due to infection, and a woman who has endometriosis. This will be the difference in their chances of success with IVF. The woman with endo will always do more poorly because she has endometriosis. We know that there is something about the pathology of that disease that impacts on egg quality, embryo quality, it impacts on endometrial receptivity, and it is still a largely not unexplored, unknown area around endometrial receptivity and endo, but do have a chat with your fertility specialist and make sure they've gone through everything. Okay, I'm a wealth of knowledge. Oh, thanks. I'm just talking. You know, guys, you know what it's like. I just get going and I can't stop. Have I missed anything? No. Oh gosh, here we are. No more questions. What are you doing to me? You're giving me an early mark. I don't think I've missed any. Well done, guys. Thanks for dropping the questions in. All right. Hey, I want to remind you, just in case there are questions still coming through, so this month is our fertility nutrition month. And I have the absolute pleasure of Steph from The Dietologist. So you can go and check her out on Instagram, The Dietologist. And she is the owner, mentor, I don't know what you call them in podcast world, but her podcast is called Fertility Friendly Food. It's really good. She had me on there as a guest a couple of episodes ago, and we had lots of fun chatting about all things to do with progesterone. Go and have a listen if you're interested in that stuff. But Steph is coming on Insta Live with me next Tuesday night. In fact, we're doing it at 5:30, just so you know. So it'll be 5:30 Perth time, 8:30 East Coast time, because I've got to go and hop on a plane in the evening. And Steph's 3 hours ahead of me, so I don't want her to be having to hop on at stupid o'clock at night. So we're going to do it at 5:30 Perth time. She's going to come on live, and I've got a whole heap of questions to ask her. And if you've got any questions, burning questions, sticking to our rapid fire Q&A rules, that you want to ask her about fertility, food, nutrition, and all of that sort of stuff, then definitely come online with us at 5:30 Perth time and drop those questions in, and you can meet Steph. And then 2 weeks later, I don't know, I think the date's the 21st-ish, Tuesday night, we're going to have our very own dietitian from Womb, Mr. Nick Nation from Nutrition Nation, who is going to be coming on and sharing some stories of success that he has had in the fertility space working with patients. So hopefully that will inspire you. So that's going to be our November. Caitlin has asked another question. Are you able to talk to the success rate of ovulation induction and also the average time to ovulate using injections? Okay. Success rates with ovulation induction. Right. So people getting ovulation induction are getting it because they don't ovulate or they don't ovulate properly. So normal ovulation happens at around about the 14-day mark. So our aim when we're giving you injections or any of the ovulation induction agents is to have you ovulate at around about the 14-day mark. Some people might go a little earlier, some people might go a little bit later. And our aim is to get you the same background pregnancy rate that you would have if you didn't have an ovulatory disorder. So if you were in your early 30s and your chance of conceiving, if you ovulated and your tubes were open and your partner's sperm was normal, if your background chance of conceiving each month is 20%, that's what ovulation induction is going to get you to. If you're not ovulating properly, or you don't know when you're ovulating, then your chance of success is kind of zero, isn't it really? Or just chance. So what we're trying to do is just to get you to the background rate of success. There are some conditions though that can take longer. And one of those is what we call hypothalamic suppression, where the brain is not sending the right signals to the ovaries because everything's kind of been shut down. Often it's associated with over-exercising or under-eating. And often we have to go really slowly with our treatment to kind of prime a system that has been asleep for a really long period of time. And we have to go low and slow, because if we stick jumper leads on the ovaries, you're going to go release a whole heap of eggs, and then we're going to cancel the cycle due to the risk of twins, triplets, and higher order multiples. So sometimes it can take longer, and frustratingly so. I've had patients who can take weeks upon weeks, 6 weeks, to actually get to the point where they ovulate one follicle. And that's ideal, but frustratingly so for patients, particularly if they don't conceive, because it really only gives them a couple of shots a year to actually ovulate. So discussion with your fertility specialist. What research does suggest, however, is that ovulation induction chances of success will decrease with the more cycles that you do. In fact, some research out of the centre where I used to work showed that it dropped down to about 5% after 3 ovulation induction cycles where you've actually ovulated. And what that may suggest is that there might be other factors that are also affecting the ability to conceive over and above not ovulating. So I do think it's worth not just going forever with ovulation induction treatment. I do think that after sort of the 3rd or 4th cycle, then you should really be reevaluating with your fertility specialist. And the other thing too is that there's still quite a lot of treatment burden associated with ovulation induction, and we don't want to continue to drag you through it. Podcast name again. The podcast name is Fertility Friendly Food. There's that alliteration. Fertility Friendly Food, by the team at The Dietologist. Oh, Sparkling 786, thank you. That's just giving me a warm fuzzy. Appreciate it. All right, what's the wait time like for seeing specialists at womb? Oh, Ali B, I know. This is the stuff that keeps me awake at night time. So to see our gynecologists, depends on what you're seeing them for. Obviously, we try very hard to triage our referrals in gynecology anywhere from 3 to 6 months. Eek, sorry. If you're willing to wait for a cancellation, sometimes we can fit you in. Our specialist women's GPs, it's around about 8 weeks. I know it's long for them too, but they are specialist GPs. Even for our allied health, it's getting out there. We have another fantastic new gynecologist starting with us in February. I'm so excited for him to come on board. Yes, it's a boy. Dr. Sean Copson will be joining us at womb. He is an ages laparoscopic specialist and is very keen in the space of endometriosis. So he will be a really welcome addition to our team, along with Dr. Bernie McElhinney, who is another ages laparoscopic specialist, and Dr. Sheetal Jalania, who is a pediatric gynecology specialist. So yes, we're looking forward to expanding our team next year, because there is such a huge need for women's health specialists and gynecologists. Well, guys, I'm going to wrap it up. Oh, there's some good questions there tonight. So just a reminder, it is Fertility Nutrition Month. Next Tuesday, 5:30 Perth time, instead of the usual 7:30 Perth time. We'll be hopping on to talk to Steph from The Dietologist. And then 2 weeks later, I think it's the 21st, we'll be chatting with Nick Nation live. Have a beautiful rest of the week. I will see you next Tuesday before I hop on an airplane off to Belgium. And yeah, I'll see you soon. Bye.